Welcome to the Funnel Effect. Today we are stripping away the surface. We're looking at a topic that really fundamentally changes how we even define heart disease.
Just a huge
A
shift.
huge shift, yeah. Moving from what's basically a plumbing problem to a biological one. We're analyzing the paper Lesion Stratification with Intracoronary Imaging. It was published in Neurointervention, that's volume 22, 2026, pages E74 to E89. And for those of you who want to track it down, the DOI is 10.4244EIJ D2500266.
And it's important to note, this isn't just one person's opinion.
Oh, not at all. This is a massive consensus document, a collaboration of some of the heaviest hitters in the field. I want to make sure we give them their due.
Absolutely.
The team behind this work is Michael McGarvey, Kalpa De Silva, Thomas R. Keeble, Thomas W. Johnson, Peter O'Kane, Ziade Ali, Shangxian Tu, Sandeep Kalra, Devaka Pereira, Philip McCarthy, Jonathan M. Hill, Jonathan Byrne, Rafal Dworkowski, and Nilesh Parikh.
That's a serious lineup.
It really is.
Yeah.
So let's set the stage. Let's start with the mental image that most people, and honestly, maybe even some doctors have, of cardiology.
Okay.
You've got a pipe, right, the artery. It gets clogged up with, grease, plaque. The flow stops.
The classic model.
So you stick a wire in, blow up a balloon, smash the grease against the wall, and leave behind this little metal scaffold, a stent, and boom, the pipe is open. Problem solved.
It's mechanical, it's plumbing, and, for 40 years, that view is pretty much dictated by the main tool we had available.
Which was the angiogram.
The angiogram.
And that's essentially a shadow puppet show, isn't it?
That is the perfect analogy. It really is. When you do an angiogram, you inject iodine dye into the artery and you take an X-ray.
Right.
So what you're seeing is the outline of the blood flow. You see the silhouette of the blockage, but you do not see the wall. You don't see the plaque itself.
It's like trying to figure out if a tunnel is safe by just standing at the entrance and looking at the size of the hole.
Exactly. Or, shouting, hello, to see if there's an echo, if a car can pass through, but you have no idea if the concrete walls are rotting or if there's a bomb hidden behind the tiles.
You are totally blind to the actual disease process.
Precisely. And the paper we're covering today really declares the end of that era. We're moving from luminology, just studying the tunnel, to true intracoronary imaging.
We're putting things inside the body.
High-tech cameras and sound waves right inside the artery to look at the biology of the disease. And our mission for this deep dive is to really understand how this technology allows us to not just fix blockages, but to predict catastrophes before they even happen.
It feels like we're finally turning the lights on inside the room. Instead of just squinting through the keyhole. But before we get to the predictions and the AI, let's open up the toolbox.
Okay.
We're not just relying on X-rays anymore. The paper highlights two main technologies that act as our eyes on the inside, IVUS and OCT.
The dynamic duo of the cath lab.
It sounds like a tech startup merger.
It does, but they're very distinct. They tackle the problem using completely different laws of physics. First, you have IVUS intravascular ultrasound.
So this is the sonar.
It is. It's a tiny catheter with a miniaturized transducer on the tip, and it emits sound waves. Those waves ping off the tissue and they bounce back.
And the superpower of sound is penetration, right? It goes deep.
It goes deep. It travels right through blood, through tissue, deep into the muscle. This is absolutely key.
So if I'm looking at a really massive artery, like the left main stem, the so-called widowmaker artery that feeds the entire left side of the heart IVUS is my go-to.
Yes, absolutely. Because the left main is big. Other technologies, they might struggle to see all the way to the outer wall in a vessel that large, but sound can penetrate right through.
I see.
IVUS shows you what we call the external elastic lamina. That's the true outer boundary of the vessel. It tells you exactly how much room you have to work with. It's like finding the studs in a wall before you try to hang a heavy picture.
It's the deep sea radar. But radar can be a little bit fuzzy, can't it? It's blobs and shapes. It's not exactly high definition.
A very good point, and that's where the second tool comes in, OCT.
Optical coherence tomography.
Right. So if IVUS is sound, OCT is light, specifically near infrared light.
So what's the trade-off here?
Well, the trade-off is that light doesn't penetrate as deep. The blood actually absorbs it, so you have to flush the blood out of the way for a second to get a clear picture. But the resolution is just staggering.
How much better are we talking?
IVUS gives you a resolution of about, say, 100 microns. OCT gives you 10 microns.
10 times sharper. That's a massive difference.
It's the difference between looking at a blurry old ultrasound of a baby and looking at a 4K photograph of it. With OCT, we are effectively doing histology, microscopic analysis, but inside a living, beating heart.
That's amazing.
We can see individual cells. We can see the tiny single-cell layer of the endothelium that lines the artery. We can see macrophages, the immune cells crawling on the plaque.
You're literally watching the cellular warfare happen in real time. But this brings me to a friction point in the source material, and I want you to help me unpack this.
Okay.
The technology sounds undeniable. I mean, it's no brainer. You'd think every doctor in the world would be using this for every single case.
You would think so.
But the paper points out this massive disparity. In Japan, 85% of stent procedures use this kind of imaging. 85%. But in the US, it's hovering around 15 to 20%. Why is American cardiology still flying blind compared to Japan?
That is the elephant in the room. And it's not a lack of technology. The U.S. has all the gear. It really comes down to a difference in philosophy, in culture, and systemic incentives.
Explain that.
In Japan, the culture of intervention is built around a kind of perfectionism. They have a stop-and-think approach. They want to understand the lesion completely from every angle before they even touch it.
And their system supports that.
Historically, yes. Their reimbursement system supported taking that extra time and care.
Whereas in the U.S., it's all time is muscle.
The U.S. model is built for high volume, high efficiency. Get the vessel open, get the patient off the table, get the next case in. And historically, imaging added time.
Right, it's an extra step.
You have to set up the catheter, do the run, interpret the images. Without reimbursement models that explicitly pay for that extra time, it's often seen as a luxury or worse, a bottleneck. There's this feeling of, I've done 1,000 of these, my hands know what to do, I don't need the camera.
But the paper is arguing that it's not a luxury anymore. It's arguing that just eyeballing it is actually dangerous.
That's the core message.
They cite this huge data pool, nearly 20,000 patients from major randomized trials, Ultimate, Illumium IV, Renovate Complex PCI. So what is the bottom line from all that massive data?
The bottom line is that the luxury saves lives. The data is unequivocal. When you use imaging to guide the procedure, you reduce cardiac death, you reduce heart attacks, you reduce the need for the patient to come back for a repeat surgery down the road. It turns out that relying on a shadow, that flat 2D angiogram, leads to mistakes. Mistakes you can't see until it's far too late. When you can see the wall, you treat the wall better.
So let's dig into those mistakes. This brings us to PCI planning. PCI, of course, being the medical term for stenting. The paper talks about knowing your enemy.
A great way to put it.
And it seems the biggest enemy isn't actually the fat or the cholesterol. It's rock. It's calcium.
Calcium is the bane of the interventionalist's existence. It truly is. We tend to think of atherosclerosis as this soft, mushy stuff like butter. But over decades, as the plaque ages, it calcifies. It turns into bone.
You mean like actual bone?
Chemically and structurally, yes. It's hydroxyapatite, the same mineral in our skeletons. Now imagine you have a metal stent. It's this intricate mesh designed to expand into a perfect circle.
Wow.
If you deploy that perfect circle inside a ring of solid rock, what happens?
The rock wins. The stent gets squashed. Right? It would look like an oval. It doesn't open all the way.
Exactly. We call it underexpansion. And I cannot stress this enough. An underexpanded stent is a disaster waiting to happen.
But why? I mean, if the blood can still get through, who cares if the pipe is an oval instead of a circle?
Because of flow dynamics. It's all about fluid dynamics. If the stent isn't perfectly flush against the wall or if it's misshapen, it creates turbulence in the blood flow.
Okay.
Instead of a nice smooth stream, you get eddies and little whirlpools. And that turbulence is a powerful trigger for the blood's clotting factors. The platelets get activated.
And then the stent clots off.
The stent thromboses. It clots off suddenly. And the patient, who thought they were fixed and went home, comes back with a massive, often fatal heart attack.
So the imaging, it tells you if the rock is there before you even think about putting the stent in.
It does more than that. It quantifies the enemy. It gives you the specs. We look for specific metrics that the angiogram just can't see. We measure the arc of calcium. Is it more than 180 degrees of the vessel circumference? We measure its thickness. Is it more than 0.5 millimeter thick? We measure its length. Is it longer than 5 millimeters?
If the answer to those is yes.
Then the imaging is basically screaming at you, stop! A simple balloon is not going to crack this.
Okay, so if you know you can't just balloon it, what do? You have to break up the rock first.
You have to modify the plaque. You have to bring in the heavy artillery. That means things like rotational atherectomy.
Which is a drill.
It's essentially a tiny diamond-tipped drill bit that spins at an incredibly high speed to basically sand the calcium down. Or we can use intravascular lithotripsy.
Lithotripsy, that's the shockwave thing, right? Like what they use for kidney stones.
The exact same concept, just miniaturized for a tiny artery. You insert a special balloon that emits these sonic pressure waves. It cracks the calcium inside the wall without damaging the surrounding soft tissue.
That's amazing.
But here's the key. You only know to pull that expensive specialized tool off the shelf if you've imaged the calcium first. If you just use an angiogram, you might not realize how thick that rock is until your brand new stent fails to open.
And then you're stuck. The paper also gets into this specific type of calcium that sounds like something out of a horror movie, the nodular calcium. And it makes the distinction between protruding and eruptive. What is the difference there?
This is a really crucial distinction that only high-resolution imaging like OCT can reliably show you. A protruding calcified nodule, or a PCN, is like a smooth bump of rock jutting into the artery.
Okay.
It's covered by a nice smooth cap of tissue. It's hard, but it's stable.
So that's the better of the two evils.
Relatively speaking, yes. The true villain here is the ECN, the eruptive calcified nodule. Now picture that same rock, but the surface is broken. It's jagged. It has lost its smooth covering.
Oh, wow.
It's essentially a piece of sharp coral reef sticking out into the bloodstream.
That sounds absolutely horrific.
It is. The surface is completely irregular, and it often has fibrin clotting material draped all over it. These are just nasty lesions. They cause stents to fail at a very, very high rate.
And the paper says something wild, that they can actually grow back through the stent.
It's unbelievable, but yes, we've seen cases where these eruptive nodules, over time, literally grow back through the metal mesh of the stent, like a weed growing through a chain link fence.
How does that even happen?
The mechanical force of the nodule just keeps pushing, and it finds a way through the struts. Knowing you are dealing with an ECN, not a PCN, changes your entire strategy.
I can imagine.
You might need to absolutely pulverize it with high-energy lithotripsy to flatten it out, or you might need to use a thicker, stronger type of stent. But without imaging, on an angiogram, both of them just look like lumps. You wouldn't know the difference.
Not until the patient came back with a failed stent.
Exactly.
So imaging helps you prep the site, but it also helps you check your work, right? The stent optimization phase.
Correct. You don't just deploy the stent and, walk away. That's the old way. The new way is you go back in with the camera.
Then what are you looking for?
You check for apposition. Is every single strut of that stent hugging the vessel wall perfectly, or is it floating in the stream? You check for edge dissections.
Dissections, that sounds like tearing.
It is a tear. Sometimes the very edge of the stent can pinch the vessel wall and cause a small hidden tear. On an X-ray, you would almost never see it.
But it's dangerous.
It can be catastrophic. That little tear can peel up later like a loose piece of wallpaper and cause a sudden, complete closure of the artery. Imaging catches these invisible errors immediately, which allows the doctor to fix them right then and there.
It really is checking your work with a microscope. Okay, let's move to something that feels more like a detective story. Section 3 of the paper. Investigating acute coronary syndromes, or ACS. This is when someone comes into the ER, they've got chest pain, they're sweating, their enzymes are up, they are actively having a heart attack.
This is one of the most exciting and, frankly, revolutionary applications of OCT, because sometimes a patient comes in with all the classic signs of a heart attack, but when we shoot the dye for the angiogram, the arteries look, well, they look fine.
This is it's not you, it's me of heart attacks. The Minoka cases, right?
Exactly, Minoka. Myocardial infarction with non-obstructive coronary arteries. For years, it was a total mystery. The pipes look open, so why is the heart muscle downstream dying?
And what does the paper say?
The paper reveals that when you put an OCT camera in there, you find the culprit in about 50% of these mystery cases.
So half the time, the answer is right there. It's just invisible to the X-ray. What are we finding? What's the cause?
We're finding the specific mechanism of the event, and this is fascinating because it turns out not all heart attacks happen the same way. The classic one, the one we all learned about in medical school, is plaque rupture.
That's the volcano model.
Perfect name for it. You have a plaque with a big, liquidy, fatty core. It's covered by a thin cap. The cap breaks, the necrotic core spills out into the blood, and the blood clots instantly around it. That blocks the flow.
And that accounts for most cases?
About 50 to 60% of them, yes. That's the classic heart attack.
Okay, so that's the majority. But what about the others?
Well, the rising star, if you can call it that, is something called plaque erosion.
Erosion. How is that different?
It's completely different. With erosion, the plaque doesn't pop, it doesn't rupture. Instead, the surface just gets scuffed. The endothelial cells, that delicate Teflon-like coating of the artery, slaw off for some reason.
So the body sees a raw surface.
The body senses this raw, unprotected surface and immediately forms a clot right on top of it. It's more like a scrape than an explosion.
And why is this a rising star?
Because it's becoming more and more common. It now accounts for maybe 30 to 40% of cases, and we think this is actually because statins, the cholesterol drugs, are working. They're changing plaque biology, they're making the caps thicker and more stable so they rupture less often, but erosions can still happen.
But does it matter? I mean, does the treatment change if it's a scrape versus a volcano? At the end of the day, a clot is a clot, right?
You would think so, but the treatment implications are absolutely massive.
Ah,
And this brings us to the erosion study concept that's mentioned in the text.
okay.
This is a huge mindset shift. If you look with OCT and you see it's an erosion, meaning the vessel structure is mostly intact, it's just a clot sitting on a scrape. Do you really need to smash a permanent metal stent into it?
I'm guessing the standard answer for the last 30 years has been yes, stent everything.
That has been the absolute dogma. But the erosion study tested a truly radical idea. What if, for OCT-confirmed erosion where the vessel isn't crushed, we just dissolve the clot with powerful blood thinners, and that's it. No stent.
No metal left behind.
No metal left behind,
Yeah.
and the results were stunning. The patients did very, very well. 92.5% were free of major cardiac events at 1 year.
That's incredible.
This is the definition of precision medicine. You're not just treating a heart attack anymore, you're treating the specific biological mechanism of that patient's heart attack. Without imaging, you would have stented both of them. With imaging, you can spare the erosion patient a permanent metal implant and all the risks that come with it.
Wow. And the paper also mentions SCAD spontaneous coronary artery dissection. This is something we hear about more with younger women, isn't it?
Yes, unfortunately. SCAD is not about plaque or cholesterol at all. It's a tear in the layers of the artery wall itself, which creates a flap that blocks the flow of blood.
And angiograms can miss that.
Angiograms often miss it, or worse, they mistake it for a typical blockage. And if you try to put a stent in a dissection as if it were a normal blockage, you can actually make it much, much worse.
Oh.
You can extend the tear, like pulling a zipper down the length of the artery. It's a nightmare scenario. But imaging clarifies it instantly. You see the intimal flap clear as day. And often the best treatment for SCAD is actually to do nothing at all and let it heal on its own.
But you can only make that call if you can see it.
You can only make that call if you can see it. Seeing is believing, and in this case, seeing is knowing when to keep your hands off.
Okay, let's pivot now from fixing problems that have already happened to, well, prediction. The holy grail of cardiology has always been spotting the heart attack before it happens, the crystal ball.
This is where we start hunting for the vulnerable plaque. The official term for the riskiest type is TCFA.
TCFA. Let's unpack that acronym. Thin cap fibrotheroma.
That's it.
So what does that look like to the OCT camera?
Visually, it's terrifyingly simple. Imagine a large pool of lipid, that's fat and dead cells, sitting inside the artery wall. And holding that toxic pool back from the bloodstream is a fibrous cap. In a TCFA, that cap is microscopically thin.
How thin are we talking?
We're talking less than 65 microns.
And for context, how thick is a human hair?
A human hair is about 50 to 70 microns thick. So we are talking about a wall, a barrier, that is thinner than a single strand of your hair, and it's holding back a catastrophic event.
And if that hair-thin wall snaps?
Rupture, clot, heart attack, game over. And the imaging can see more than just the thickness. It can also see macrophages, those white blood cells, infiltrating the cap.
Which is a bad sign.
It's a terrible sign. It's a sign of active inflammation. It means the plaque is angry. It's being actively attacked by the body's immune system, which makes it even weaker and more prone to rupture.
So we can see these ticking time bombs.
Yeah.
Is there solid evidence that spotting them actually predicts future risk for a patient?
Oh, absolutely. The paper cites major studies like Prospect 2 and Combine OCT, and the data is just striking. For example, in the Combine OCT trial, they looked specifically at diabetic patients.
A very high-risk group.
Extremely high risk. And they found that if a patient had one of these TCFA lesions, the thin cap, their risk of cardiac death or heart attack was 5 times higher than a diabetic patient without one.
5 times higher. That is not a small margin of error.
It's a massive signal, and we have another tool to help us spot them, which the paper calls the chemist catheter.
The chemist.
NIRS, near-infrared spectroscopy.
Why the chemist?
Because while IVUS and OCT show you the structure, the anatomy, NIRS detects chemical composition. It's specifically tuned to hunt for for fat.
So it's a fat detector.
Essentially, yes. It creates a map of the artery called a chemogram. It literally paints the parts of the artery wall yellow where there is a high concentration of fat.
It's a literal treasure map, but the treasure is cholesterol.
A danger map, really.
Yeah.
It generates a score, a number called the LCBI, the Lipid Core Burden Index. And we know that if you have an LCBI score greater than 400 in any 4-millimeter segment, that is a major red flag.
How big a red flag?
The hazard ratio for a future cardiac event is 3.39. It's a powerful predictor.
Okay, so we have the camera, the OCT showing us the thin cap, and we have the chemist, NRS, telling us there's a massive pool of fat right behind it. But here's the bottleneck I see. Analyzing all these images, measuring microns, calculating lipid indices. That sounds like it takes a PhD and a lot of time.
Yeah.
You're a doctor in the middle of a busy lab, you're stressed. Do you really have time to sit and measure microns?
And that has been the major criticism for years. I'm in the middle of a procedure. I don't have time for a science project. It's a valid point.
So what's the solution?
Enter the AI revolution.
I knew AI had to show up eventually. It always does.
It's the only way to scale this. The paper discusses new software, new algorithms that can do all of this analysis, measure the calcium arcin thickness, detect the lipid pool, measure the cap thickness down to the micron in about 25 seconds.
25 seconds.
From a full pullback. It completely democratizes expertise. You no longer need to be a world-renowned expert who has spent 20 years reading OCT images. The AI highlights the vulnerability for you automatically. It turns an average operator into a master analyst instantly.
That helps with the anatomy, the structure.
Yeah.
But what about flow? I know the traditional way to see if a blockage is actually slowing down blood flow is to use a pressure wire.
That's right. The gold standard has been fractional flow reserve, or FFR. You pass a tiny wire with a pressure sensor across the blockage.
But now AI is changing that too.
Now, AI brings us what the paper calls morphofunctional assessment. It's a mouthful, but it means merging form and function.
Explain that.
We now have OFR, which is OCT-based FFR, and VFR, virtual flow reserve. The AI takes the 3D geometry of the artery from the images and uses computational fluid dynamics, the same physics used to design Formula One cars, to calculate what the pressure drop would be across the blockage.
So you don't even need the pressure wire anymore.
No wire, just the image. And the accuracy is stunning. OFR has about a 93% accuracy when compared to the physical wire, and the calculation takes less than a minute.
Wow.
So in one single pullback of the camera, you get everything. You get the anatomy, what it looks like, and you get the physiology, how it's affecting blood flow. It completely removes the old debate of morphology versus physiology. You get both at the same time.
That is true efficiency. But let's get to the really controversial part. Section 6, the future of therapy. We've found these vulnerable plaques. We know they're ticking time bombs. They haven't ruptured yet. They aren't even necessarily blocking flow.
Right.
But we know they're dangerous. Do we touch them?
This is the biggest, most contentious debate in cardiology right now. The dogma for my entire career has been, if it's not blocking flow, if it's not ischemic, you leave it alone. Treat it with pills, but you do not stent it. You don't fix a pipe that isn't clogged.
But that's being challenged.
It was challenged in a huge way by the PREVENT trial, which was just published in 2024. It's a landmark study.
What did they do?
They took patients with these high-risk, vulnerable plaques that were confirmed with imaging, but were not blocking flow non-ischemic lesions. They randomized them into two groups.
Okay.
Group A got the standard of care, just pills, medical therapy. Group B got preventative stenting. They went in and put stent on that non-obstructive plaque just to cage it, to stabilize it.
Stenting a blockage that isn't really a blockage, that sounds incredibly aggressive. It breaks all the rules.
It breaks every rule we were taught. But the result was that preventive stenting reduced major cardiac events by an absolute 3% at 2 years.
3% sounds small, but in population terms.
It's hugely significant. It's a proof of concept that mechanically stabilizing a dangerous plaque works. However, you can't just go around stenting everything. Putting metal in carries its own long-term risks.
Oh, what's the alternative?
Well, the paper discusses systemic therapies. If we see these high-risk features, maybe the answer isn't a local fix, but just stronger drugs for the whole system.
High-intensity statins, things like that.
Exactly. And the newer drugs, like PCSK9 inhibitors, Imaging studies have shown that these drugs can achieve what we call triple regression.
Triple regression.
We see the plaque volume shrink, we see the lipid core inside it shrink, and most importantly, we see the fibrous cap get thicker. We are essentially remodeling the wall chemically to make it safer.
And colchicine. That's a gout drug, isn't it?
It is. But it's a powerful anti-inflammatory. And since we now know inflammation drives plaque rupture, remember those angry macrophages we saw? It makes perfect sense. And sure enough, OCT studies show that colchicine can increase cap thickness. It calms the angry plaque down.
But the ending of this paper, I mean, it goes full science fiction. It talks about theranostics. This is where my mind was truly blown.
This is my favorite part, too. It's the future. Theranostics is the combination of therapy and diagnostics in one device.
Okay.
The paper mentions a study. It's in rabbit models for now, but moving forward, that uses a technique called photoactivation.
Walk us through this slowly. This isn't just taking a picture anymore.
Not at all. Step 1. You inject special nanoparticles into the patient's bloodstream. These particles are engineered like tiny homing missiles to bind specifically to the macrophages, the inflammation cells that are living inside the plaque.
Okay, so the plaque is now tagged. The bad spots are painted with these invisible particles.
Precisely. Then, step 2. You insert a special imaging catheter. This catheter doesn't just take pictures, it's also designed to emit a very specific frequency of light.
And when that light hits the nanoparticles,
It activates them. It flips a switch.
a switch that does what?
The activation could release a potent anti-inflammatory drug that was carried by the particle, or it might create a mild thermal effect that just neutralizes the macrophages. You are literally zapping the risk from the inside, using light to treat the biology of the vessel wall without leaving any metal behind.
That is absolutely mind-blowing. No stent, no long-term implant. You just go in, clean the pipe with light, and you come out.
It completely changes the definition of treatment. We move from reactive waiting for the crash to proactive. We're fixing the dangerous potholes in the road so the crash never, ever happens.
It really connects all the way back to the beginning, doesn't it?
Right.
We started this conversation talking about shadows, and now we're ending it by talking about interacting with nanoparticles using targeted light.
It's the complete evolution from luminology to plaque biology. We can now classify risk with incredible precision. We know if it's a TCFA, a lipid-rich plaque, or a calcified nodule. AI makes this analysis fast enough for any doctor anywhere to use.
And treatments are shifting from just crude plumbing to elegant biological stabilization.
Exactly.
So what does this all mean for you, the listener? It means the next time you or a loved one might need a heart procedure, the question shouldn't just be, is it blocked?
The question should be, what is the blockage made of?
And can we stabilize it before it ever causes trouble?
That's the key.
Which brings us to a final provocative thought to leave you with. If this AI and imaging can spot a potential heart attack years in advance, identifying those thin caps long before they snap will preventative stenting, or maybe even this futuristic light therapy become as common and routine as a dental filling.
It's a completely valid question. I mean, think about it. We don't wait for a tooth to rot out of our head before we agree to fill a cavity. So why do we wait for an artery to completely close and cause a heart attack before we treat the disease in the wall?
Are we moving toward a world where cleaning your arteries is a scheduled maintenance event, like getting an oil change for your car? The very definition of a patient could be about to change from someone who is sick to someone we are actively keeping from getting sick.
And that is a future that's worth working toward.
Thank you for watching The Funnel Effect.